Today we will discuss regarding proportionate dwarfism. So what is dwarfism? Dwarfism is also called as short stature. So if the growth is below third percentile for the corresponding age and sex, we call it as either dwarfism or short stature. So what is a normal growth? If a child weighs, if its height is between third to 97th percentile in any standard growth charts like WHO version or IAP version, we call it as normal growth. Okay. So the normal growth is influenced by genetics, nutrition, lack of intrauterine growth retardation, lack of starch infection, normal hormonal profile, absence of chronic disease, and proper psychosocial environment. So short stature occurs if there is a problem with any of these things. Now, how is short stature classified? Short stature is classified into proportionate dwarfism and disproportionate dwarfism. Today we will discuss in detail regarding proportionate dwarfism. So in case of proportionate dwarfism, there will be uniform retardation of growth. Whereas in case of disproportionate dwarfism, the abnormal body proportions will be seen usually seen in skeletal dysplasias. When do we call dwarfism or retardation as a uniform? So for that we should understand what is body proportion and segmental ratios. We usually divide our body into two halves. One is upper segment, the other one is lower segment. So upper segment constitutes from head to symphysis pubis. So lower segment is from symphysis pubis to lower limb. Okay, so this is what we call it as upper segment versus lower segment. Normally, the upper segment is to lower segment ratio is unaltered in case of proportionate dwarfism. So here, though the child technically lies between third percentile, the ratio between upper body as well as the lower body will remain normal to this particular age. Actually, for every age, this will vary. So, how much it will vary? So, at birth, the ratio is 1.7 to 1.8 is to 1. Whereas, in case of 3-year-old child, it will be like 1.3 is to 1. And from 8 to 10 years, it is 1.1 is to 1 roughly. By adult, it reaches to 1.1. So, this ratio is maintained in proportionate dwarfism. Whereas, in case of disproportionate dwarfism, this will show abnormal ratio, which will be usually lower. So, the dwarfism is classified into two types, proportionate dwarfism and disproportionate dwarfism. In disproportionate dwarfism, the upper segment versus lower segment ratio remains normal to that age, whereas it remains lower usually, but you can say abnormal. So this is what is present in disproportionate dwarfism. Now coming to the etiology of proportionate dwarfism. So in case of proportionate dwarfism, the etiology could be due to endocrine, where there will be growth hormone deficiency, hypothyroidism, or Cushing syndrome. Then nutritional causes like a chronic protein allergy malnutrition, sometimes due to systemic causes like renal disease, cardiac illness, or congenital heart disease, then chronic infections, sometimes also due to celiac disease, because in celiac disease, despite normal intake, there will be malabsorption of food resulting in malnutrition. So this will be due to malnutritional, but the underlying cause will be GI cause. In case of genetic issues like Turner syndrome, Down syndrome, Prader-Willi syndrome, then this could also be familial, constitutional delay, or intrauterine growth retardation. So there is a difference between familial and constitutional delay. So what is familial and what is constitutional delay? So in case of familial, there will be a family history of dwarfism. Here there will be a family history of delayed puberty. So whenever the child's height is measured at any point of time, the child will remain with a short stature in less than third percentile. Here also the same will happen, but when they were approaching puberty or after approaching puberty, the child will be not having any short stature. This will actually get into normal. So this is what we call it as constitutional delay. So how do we find that? For that we know what is target height. So target height, it is also called as a mid-parental height. Mid-parental height. So in case of mid-parental height is father's height plus mother's height plus 13 divided by 2 for boys. As far as girls are concerned, it will be father's height minus plus mother's height minus 13 divided by 2. This is for girls. So if the child's target height is intact, then usually this will result in familial short stature. Now, what is the pathophysiology? So there will be uniform retardation of cellular growth. Usually, growth hormone deficiency induced one will be like this, where there will be low IG1, then reduced cartilage proliferation. In case of hypothyroidism, there will be delayed ossification as well as metabolism. In case of malnutrition, there will be suppressed anabolic activity. So the body will appear normal in proportion, but overall there will be short stature. Childlike face will be present, immature voice, especially in boys, and there will be delayed bone age. So there is a difference between bone age and chronological age. So bone age is defined based on the ossification centers present in different parts of the bone that are supposed to mature and the fusion of epiphyseal plates. So based on which bone age will be determined. So in case of neonates, it will be bone age will be assessed through knee. In case of infants, it will be assessed through shoulders. In case of older children, it will be assessed through wrist and hand X-rays. So all these X-rays are required to assess bone age. Then intelligence will be normal in growth hormone deficiency, but low in congenital hypothyroidism, and there will be dry skin, puffy face, obesity in other endocrine organs like Cushing's syndrome. Now, coming to system specific findings. So there was in the skeleton there will be delayed bone age, small hands and feet, delayed epiphyseal closure, absent or delayed secondary sexual characters. Normal intelligence will be present in growth hormone deficiency, but in case of congenital hypothyroidism, there will be delayed milestones. There will be no developmental delay. So the child will have normal social, gross motor, fine motor, and language development throughout childhood in case of dwarfism. So hypoglycemia will be there only in severe growth hormone deficiency. In case of cardiovascular system, there will be bradycardia and low pulse pressure in hypothyroidism. The facial features include puffy face, fats, hair, macroglossia in hypothyroidism, and cerebric face in GH deficiency. So coming to diagnostic approach, the diagnostic is mainly clinical, wherein anthropometry measurement of height, arm span, and segmental ratios are measured. We can also check for bone age to some of the differential diagnosis, X-ray of left hand or wrist usually, and depending on the age, if it is endocrine profile of growth hormone, IGF-1, TSH, T3, T4, and cortisol, then karyotyping for Turner syndrome, MRI for pituitary defects, then CBC, ESR, renal and liver function test. Then also serum calcium, phosphate, alkaline phosphatase can also be done for. In case of radiological finding, there will be delayed bone age, small cellular tunica in growth hormone deficiency, and epiphyseal dysgenesis in hypothyroidism. There will not be any limb deformity unlike in skeletal dysplasias. So differential diagnosis include achondroplasia, hypothyroidism, growth hormone deficiency, Turner syndrome, and chronic malnutrition. So in achondroplasia, the dwarfism will be disproportionate. In others, it will be proportionate. But in case of hypothyroidism, there will be low IQ, dry skin, and coarse features. Growth hormone deficiency, there will be truncal obesity and childlike face. Turner syndrome, webbed neck, and primary amenorrhea. Chronic malnutrition, it will be associated with underweight and stunting. Coming to the specific management, in for growth hormone deficiency, recombinant growth hormone of 0.03 mg per kg subcutaneously at night. Hypothyroidism requires a lifelong levothyroxine therapy. Turner syndrome requires a GH therapy and estrogen replacement after 12 to 13 years. Chronic illness requires treating the underlying condition, and malnourishment, so nutritional rehabilitation center with a protein-rich diet. Constitutional delay all it requires is reassurance and periodic follow-up. So coming to the supportive measures, nutritional support, physiotherapy, and counseling. See, counseling is one important thing because maternal deprivation of love is also considered as one of the reasons for short stature, which we call it as psychosocial short stature. Then regular growth monitoring every 6 months and educational and psychosocial assistance are required as supportive measures. So coming to prognosis, excellent in growth hormone deficiency and hypothyroidism if early treatment is initiated. It is quite good in constitutional delay where the height will be catching up after attaining puberty, though it might be delayed, and it is guarded in genetic and syndromic cases and poor if diagnosed after the epiphyseal closure is made. Long-term sequelae may be short adult stature, infertility, osteopenia, obesity, metabolic syndrome, psychosocial issues like low self-esteem and depression, delayed cognitive emotional maturity in untreated cases. So coming to the preventive aspects, antenatal care to prevent IUGR, newborn screening for hypothyroidism. This is mainly to prevent the torch infection. Then growth hormone growth monitoring in schools, because growth hormone deficiency usually can be suspected after the child goes to school. Nutritional education and genetic counseling are also important. Now, the take-home message is proportionate dwarfism is characterized by uniform retardation of growth, where the limb, trunk, head remain in normal proportion. The most common causes include growth hormone deficiency, hypothyroidism, chronic malnutrition, systemic diseases, and certain genetic syndromes like Turner or Down syndrome. Early diagnosis through growth monitoring, bone age assessment, and hormonal evaluation is key to effective management. Puberty delay is a hallmark, and timely hormonal replacement therapy can achieve normal sexual maturation and better adult height. Recombinant growth hormone and thyroid therapy, when started early before epiphyseal closure, offers the best prognosis. Long-term sequelae such short stature, infertility, metabolic syndrome, psychosocial stress can be prevented with regular follow-up and multidisciplinary support. Ultimately, growth charts, awareness, empathy remain the most powerful tools in ensuring every child with short stature receives timely care, confidence, and a fair chance for a healthy life. I hope you have learned about the proportional dwarfism in this class today. Thank you.